it's 7:30, so we should kick things off. Good evening to everybody, and welcome to November's LVS film reading session. For those of you who are new to these sessions, my name is Ian, and I'm a radiologist. I graduated from the RVC in 2004. I got my imaging certificate in 2009, and finally got my European diploma in diagnostic imaging in 2018. And these days you can find me at London Veterinary Specialists, which is the only multidisciplinary referral hospital in central London. We're situated in Belsize Lane, and if you guys have any problems with anything imaging related, if you'd like to have a chat about which imaging modality you think would be most useful to help you make a diagnosis, or if you have some radiographs that you'd like a hand with, then don't be a stranger. Give me a call at the clinic or drop me a line via email. So these sessions involve us discussing 4 cases. Hopefully you will have had a chance to review each of the cases prior to this evening's session. I usually recommend that you spend no more than 15 minutes per case. Have a look at all of the radiographs, come up with a radiographic description using all of the buzzwords you can think of to describe the lesions that you've identified. Write some conclusions, which should include an ordered list of differential diagnoses, and then make any recommendations that you think are appropriate. So for a case where you are suspicious of a mechanical ileus and you think an abdominal ultrasound might be useful, you can recommend that. For a case where you're suspicious there might be some subtle pulmonary lesion and you think a thoracic CT might be useful, you can make that recommendation, because there might be some additional imaging for us to review and discuss during this evening's session. So we're going to do something a little bit new this evening. We're going to use a web-based polling system to try and get all of you involved. So you will each still be asked to volunteer to present one of these cases, but that means that only 4 of you will actively be involved in contributing to the discussion. A good way to get you all involved is potentially to try and get this polling system up and running. So the way to take part with the online polling is to go to pollev.com to enter my username, which for reasons known only to Paul everywhere is Ian David Joni 636. And you should, in due course, see some questions appearing that relate to this evening's cases. And when you see a question appear, then you should select the response that you feel is most appropriate, and hopefully we can all then share those responses and see how the group has responded to each of these cases. This is the first time we've tried this, so there's no guarantee that it's going to work, but it could be fun. And like I say, it'll give everyone a chance to take part. So before we do anything else, let's see if this is working. So I'm just going to go back to this slide. In order to take part in these online polling sessions, like I said, go to PolleV, type in Ian David Jones 636, and then respond to the questions that appear. Okay, so hopefully you guys have got that information. So the first question essentially is this working? And if it is working, then once I activate this question, which is this working, you guys should see that appear on your screens if you've all logged in, and then we should see some results start appearing, which they are. So I can see that 6 of you have responded, which is excellent. So with the 6 responses, I'm now going to see if this will sync up to my PowerPoint presentation. And if it does, then we should see the results live, which will be super fun. It does look like it has worked. So there we go. That's all 7 people that participated commenting that this polling system is working, which is excellent and super exciting. So before we get too carried away with the web-based polling system, the routine is for me to present an example before I hand the floor over to you guys. So this is actually a case that we reviewed last week. It's a 4-year-old male neutered greyhound that presented as coughing. For those of you that attended last month, rather, you will hopefully recognize this radiograph. So this is just a single right lateral radiograph this time. I'm not going to review all of the views of this patient. Just one is all that's required for this example. And there is a clearly marginated focal area of increased opacity in the dorsocaudal thorax. The remainder of the thorax is within normal limits. So the cardiac silhouette, the pulmonary vasculature, the mediastinum, the mediastinal structures, and the extrathoracic structures, including the ribs, the thoracic vertebra, and the sternobra, all look fine. Given this is a young dog, so a 4-year-old greyhound that's coughing, we need to be mindful of that when we come up with our ordered differential list. So in a 14-year-old dog, seeing a clearly marginated focal area of increased opacity like this, we would certainly start thinking about something sinister, like a bronchoalveolar carcinoma. And that is still on the differential list. However, given this dog is quite young, we need to consider other things, like potentially a bronchial foreign body giving rise to an abscess or a granuloma. And the reason why I've included this case as an example is because since I last spoke to you, we have CT'd this patient. So I thought it might be useful just to have a look at the CT, just to keep you guys up to date in terms of how these patients you're assessing during these sessions are progressing. So we'll just have a little drive through this CT. So this is a lung reconstruction. It's a 2.5 millimeter lung reconstruction, and we're moving from cranial to caudal. We're just passing the cardiac silhouette, and we're coming to the area of interest, which is the left caudal lung lobe. I'm going to pause it just there. So in this image, we can see a clearly marginated area of hyperattenuation, and this is the lesion that we could see on that right lateral thoracic radiograph. Now, not only can we see this focal area of hyperattenuation, the adjacent bronchi are also enlarged, and it's the bronchi that are closest and associated with this lesion that are most enlarged. So we'll just run it on a little bit more. And just as we get to the caudal edge of that left caudal lung lobe, we start to see more of these enlarged bronchi that have very thick walls. So the wall of this bronchi in particular, very thick, and we've also got evidence of hyperattenuating material within the bronchial lumen. So these structures here, I think, are bronchi. You wouldn't normally see them. They're way bigger than they should be, and they're full of hyperattenuating material. Normally, we'd expect the bronchi to taper and thin out as they extend from the deeper parts of the lung towards the periphery. But these bronchi, they're staying very large, and that's quite a significant abnormality, and might clue us in as to the origins of this lesion. And again, sliding caudally, more enlarged bronchi with thick walls and more hyperattenuating material within the lumen of these peripheral bronchi. So the CT essentially confirms our suspicions. There is a large, solitary, clearly marginated, hyperattenuating lesion within the left caudal lung lobe. We've also got evidence of local bronchial wall thickening and enlargement of the bronchi that are adjacent to this lesion. And that enlargement of the bronchi extends towards the periphery. And just at the periphery, we've got several focal large bronchi. So we could potentially go as far as saying that there is a very mild saccular bronchiectasis here, and we've got a huge amount of debris within the bronchial, within the bronchi and the bronchial lumens associated with this lesion. So that's the lung reconstruction. Let's let that play through again. And we'll just move on to the soft tissue reconstruction, which is just here. So essentially same region, same dog, but different reconstruction. So this is a 2.5 millimeter soft tissue reconstruction. It looks a little bit different in terms of the contrast, and that's deliberate. So the reconstruction kernel here is tailored to give us most detail about the soft tissues. And this is a post-contrast sequence. So we've already given the patient some intravenous contrast material here. So again, moving from cranial to caudal, and the area that we're interested in is the left caudal lung lobe. So that's going to appear in just a moment. This is the heart. You can see it's full of contrast. And I'm going to stop it just about here. So this is our lesion. Looks different in this reconstruction because it's a soft tissue reconstruction rather than lung reconstruction. And the thing that's significant here is the pattern of contrast enhancement. So hopefully you guys can appreciate that the periphery of this lesion is really strongly enhancing. It's lighting up like a Christmas tree, whereas the center of this lesion not really enhancing at all. So we've got very strong peripheral enhancement, and we've got negligible central enhancement. And that's something that is very typical of an abscess. And the fact that we've got these associated bronchial changes, we've got lots of hyperattenuating debris and material within the bronchial lumen, and we've got evidence of bronchial wall thickening and saccular bronchiectasis, suggests that this abscess has been caused by an intraluminal bronchial lesion. So something has got stuck in the lumen of that left caudal lobar bronchus, and as a result of that, it's caused this focal hyperattenuating solitary mass lesion that's exhibiting very strong peripheral but negligible central enhancement. And because it's an intraluminal bronchial problem, we've got these secondary bronchial changes like the saccular bronchiectasis, the thickened bronchial walls, and the material within the bronchial lumen. So the conclusion that we came to after looking at the radiographs last month and also after looking at the CT that we've done subsequently is that this is most likely a pulmonary abscess secondary to a bronchial foreign body. And that's indeed what it turned out to be. So really nice case, and this patient is recovering pretty well after a slightly rocky post-op period, now doing really nicely. So I thought as the example, I would share that with you guys because you saw it last month and reported on the radiographs. So that's enough from me for the time being. It brings us on to case number 1, which is a 1-year-old female neutered Chihuahua that's presented to you as retching. And I've only given you guys just the one radiograph to look at here. So it's now time for me to open up the floor and invite you guys to share your thoughts on what might or might not be going on here. So who feels like they might want to present case number 1?
I can do it, Ian.
Yeah, that's great.
Okay, so we've got a right lateral X-ray dog. I could see in the distal, showing the distal cervical spine and thorax. I could see an abnormal gas pocket just below C5. I thought it wasn't like a usual shape of a gas pocket I would see in the esophagus, I didn't think.
Yeah.
And then just beyond it, I thought I could see a soft tissue opacity. The trachea just ventral to that region looked like it was possibly being a bit compressed, and then as you go into the thorax, it seems to go back up dorsally again, which I wasn't sure whether it was either being compressed from above or whether there could be some kind of weird lymphadenopathy below the trachea. I'm not sure because it goes up quite high.
Yeah.
And then the trachea looked a bit narrow as it went through the thoracic inlet. There's a bit of gas just above and slightly cranial to the carina, which I presumed was in the esophagus as well, but not enough to say that it was like a megaesophagus or anything like that. But I wasn't sure whether the patient was sedated or not. If it was conscious, then I'd say that probably is a bit abnormal.
Yeah.
And then also there's a lot of gas in the stomach as well.
Yeah.
Other than that, I thought the liver maybe looked a little bit small, but I'm not sure. So my conclusion was that there was a possible foreign body in the esophagus, just cranial to the thoracic inlet.
Yeah.
And
Okay.
I recommended endoscopy.
Okay, great. No, that all sounds good. So what we're going to do before we run through it, let's just open this up to your colleagues. So in just a moment, I'm going to activate question number 2. And hopefully you guys should see the question that is on the screen. A couple of responses, which is great. Okay, so let's sync this up and see what the people think. Okay, wow, so 100% feel that you're absolutely right, and this is most likely to be a gastrointestinal problem, and I absolutely agree, and I thought your description was excellent. So you're absolutely right for your eye to be drawn to this area here at the level of the thoracic inlet. And I completely agree that it's not normal to see a focal area of gas lucency at this point, probably within the esophagus. And the fact that the trachea is displaced ventrally around that area is also a little bit concerning. We can see that it tracks ventrally, and then as the trachea moves into the cranial esophagus, as you pointed out, it shifts and curves dorsally again. So it almost looks as if there's something in this area here that's flattening and displacing that trachea ventrally. And this is a young, small dog, and it's presented as retching. So something like an esophageal foreign body is absolutely on the differential list here, even before we think about acquiring radiographs. Some of the other changes that you've pointed out, I also completely agree with. I think that there is some gas here within the esophageal lumen, just at the level of the hilus, and the stomach is indeed full of gas. So this patient undoubtedly is swallowing a lot of gas for whatever reason. So there's a lot of aerophagia that's resulted in the stomach being filled with gas and there being some gas within the thoracic esophageal lumen. And in terms of your conclusions, you're absolutely right. So this structure here, which is pretty tricky to see, so it's reasonably poorly marginated. The reason we can actually see the foreign body, which is just here, is that it is surrounded just by a very thin border of gas. So we've got just a very subtle gas-lucent border surrounding this structure. And it's in a location where you'd expect to see esophageal foreign bodies. So esophageal foreign bodies typically are going to get stuck at the level of the thoracic inlet. They can get stuck just before the heart or just after the heart. And this one has got stuck at the level of the thoracic inlet. And yep, you're absolutely right. This little chihuahua had an esophageal foreign body that was removed with endoscopy and did very well. So as far as I'm aware, made a complete recovery. So the only other thing that I would be mindful of and always remember to check when you have patients presenting with things like esophageal foreign bodies is there any evidence of any aspiration pneumonia? So if you've got an obstruction in the esophagus and the patient has been retching and potentially regurgitating and vomiting, then they're at risk of aspiration. So it's worth taking a little bit of extra time just to make sure there's no evidence of aspiration pneumonia. So aspiration pneumonia, typically has a ventral distribution, and it's typically the right middle or the cranial lung lobes that are affected. And in a lateral radiograph such as this one, we'd expect to see some evidence of consolidation superimposed over the cardiac silhouette and potentially ventrally affecting the cranial lung lobes. And I don't see any evidence of aspiration pneumonia here. So I think you were right not to mention it. So yeah, good job. Anybody have any questions about case number 1? In which case, we shall move swiftly on to case number 2, which is a 3-year-old male-neutered Dachshund as presented as vomiting. And for this case, I've given you 3 views. So you have a left lateral, you have a VD, and you have a right lateral. So anybody fancy case number 2, which is little vomity Dachshund?
I'm happy to have a go at it, Ian.
Yeah, fab.
Starting with the right lateral, I think there's some reduced serosal peritoneal detail, mainly cranially and caudally. I think it's all right in the mid-abdomen. In the left lateral, I think the gastric axis is more horizontal than it should be. I think in the left lateral, it should be kind of perpendicular to the spine.
Okay.
In the caudodorsal abdomen, there's a very well marginated round structure, which I think is heterogeneous, soft tissue to kind of mineral dense in opacity, and it's just ventral to, I think, L4, L5. I think it's surrounded by gas-lucent bowel. I'm not entirely sure if it's small bowel, large bowel, or cecum. I think there's 2 populations of small bowel. I think some are soft tissue in density, and there are other ones that are gas-filled and perhaps comma-shaped. Then moving on to the orthogonal view, I think I can see that structure just lateral to, I think that's L6. And again, it's round, well marginated.
This thing here.
Just to the right of where your cursor is, and slightly down.
Here.
Sorry, just kind of superimposing over the vertebra.
Oh, okay. This kind of.
I think the fact that you don't know what it is suggests it's not a finding.
Could very well be so.
I think I saw relatively similar things on the right lateral as well. I can see that structure in the caudal dorsal abdomen. I think there's still 2 populations of small bowel. So I do think it's mechanical ileus. But from your question, I'm worried I may have missed something.
No. Okay. So yeah, agree with a lot of those findings. So just for fun, and because this system does seem to be working, which is a minor miracle, let's just open up this to the floor, and based on the discussions that we've had so far, what do we think we should do? So do we think we should take some more radiographs, or are we happy enough? Would you guys be a little bit more reassured if we did an abdominal ultrasound and took a look at the stomach and the gastrointestinal tract? Are we sure enough about what's going on, that there's a mechanical ileus here, that we're just going to crack on and we're going to cut this patient? Or is anybody feeling old school and thinks a barium study might be useful here? So let's activate that question and let's see what you guys think. Okay, so the results are on their way. 8 people responded. Let's see what we think. So about a third of you would crack on and would cut this beast, and 2/3 feel that they want a little bit more information and would do an abdominal ultrasound. And I don't think either of those responses are unreasonable here. So let's just take another look at these radiographs. So we're going to start with the left lateral radiograph. So this is a left lateral. If we think about where the stomach sits, the pylorus is on the right. So this is a left lateral, which means that all of the gas in the stomach is going to move to the level of the pylorus, which means that this big gas lucency here represents gas within the gastric antrum and the pylorus. And immediately you start focusing on this area here, you see this structure, which is a clearly marginated focal area of increased opacity. And if this pylorus were empty, then we wouldn't expect to see that. We just expect to see gas within the lumen of the gastric antrum leading to the pylorus. And if this structure was mobile and was free to just bounce around the stomach, there isn't really any reason why it should be in the non-dependent part of this stomach and be this visible and surrounded by gas in the left lateral projection. So immediately that you take a left lateral projection and you see something within the pylorus like this, which is a focal area of increased opacity, you need to start thinking whether or not this could represent something stuck within the pylorus. So this is effectively a gastric outflow obstruction secondary to a foreign body that's got stuck at the level of the pyloric outflow. So we see this structure here and we're thinking that doesn't look normal at all. Is there a chance that it could be something stuck in the pylorus? And as we start to move our eyes caudally towards the rest of the abdomen, you've picked out some of the most significant radiographic features here that are going to help us make the diagnosis. So you've picked up on the fact that we've got a lot of material within the lumen of the bowel that is quite heterogeneous. And you're absolutely right, it's very tricky for us to know whether we're looking at large bowel or small bowel in much of this abdomen. We've got this structure here, which we're a little bit concerned about, and I agree, it looks very heterogeneous. There's no real way here of telling whether that's colon, whether that's small bowel. That's some fecal material there in the lumen of the rectum. It doesn't look the same as the material that we're seeing in the bowel here, so that could easily be some foreign material. You've also commented on the shape, the size, and the distribution of the gas within the small bowel. And that's absolutely key. And you mentioned that some of these focal areas of luminal gas had a comma shape, and I think that's absolutely true. Some of them do look like little commas. And there aren't two really distinct populations of bowel here. So when you're dealing with a mechanical ileus, that's something that you look for as a really pertinent radiographic change. So one population of bowel that's really dilated and full of gas or fluid, another population of bowel that's really small. So here we've got a whole bunch of bowel. It's not really clear whether it's small bowel or large bowel, but it all seems to be kind of bunched up in the middle of the abdomen. We've got some weird looking heterogeneous material that is in some of these loops of bowel. And then we've got this funny gas pattern where some of the gas seems like it's sort of squished up on itself, so it's forming these little commas. And we've also got this thing that's lodged in the pylorus, which is all a bit of a concern. The changes in the VD and in the right lateral are quite similar. In the VD, the stomach here looks really big in this VD view. And again, that's a bit of a worry, given that we're concerned about a gastric outflow obstruction here, and there could be something stuck in the pylorus. Because this is a VD view, we're not getting gas within the pylorus in this view, which is why we can't see that structure sort of sticking out and sticking into that gas opacity. But we have got this heterogeneous material on the right abdomen cranially, which could easily be within the duodenum. And then the distribution of the intestines and the gas pattern here also quite abnormal. So we've got, again, these little focal areas that look a little bit common shaped. We've got potentially got some stacking of the bowel here. And you're right, there are some loops of bowel here that look a little bit bigger, a little bit more dilated than others. Not so dilated that you'd make the diagnosis of a mechanical ileus just based on the size of the bowel, but it's a concern that you have some segments of bowel that are quite small, some segments of bowel that are a little bit larger. And in the right lateral, so again, think about the position of the stomach. You're in right lateral, so all of the gas is going to go to the lumen, which means that this structure here is probably the pylorus. And again, the stomach here looks really big, so this stomach is kind of full of fluid and stuff. And then you've got this same heterogeneous material that is at the level of the pylorus that looks like it's extending caudally into the mid-abdomen. So this is probably pylorus here, and then this is probably whatever this material is extending into the duodenum. And again here, really strange gas pattern. We've got these little focal areas of gas that now we're thinking, actually, the fact that we've got all these little comma-shaped areas of gas and these little focal areas of gas, we can be pretty confident that this bowel, it's all bunched up. It looks like it could be placated. So we've got potentially something stuck in the pylorus. We've got heterogeneous material that looks like it's at the level of the pylorus and it's extending through the pylorus into the duodenum, and we've got associated potential placation of the bowel. And all of that means that we can conclude that absolutely there is a mechanical ileus here, but we can go beyond that and say that we're suspicious that there is a foreign material anchored at the level of the pylorus that's extending into the duodenum, and there's associated placation of the small bowel. So we're concerned that we've got a linear foreign body that's anchored at the level of the pylorus. And that's really typical in dogs, to have a fabric foreign body, for example, get stuck at the level of the pylorus and then extend little strings through the pylorus into the duodenum and beyond. So beyond the duodenum, the caudal flexure into the jejunum, and then for the rest of the small bowel to start concertinaing up around those strings and become placated. And that's essentially what happened here. So this is a fabric foreign body. It had got stuck at the level of the pylorus, and then it was extending lots of strings and tendrils into the duodenum, which and the jejunum, which was all placated up around it. And yeah, that all got removed via a gastrotomy, and Mr. Ildashian did very well. So things to take away from this case. This case, I think, demonstrates the benefit of taking 3 abdominal views in patients presented as having a suspected mechanical ileus. So this left lateral view of the abdomen here, super useful because we can actually see the foreign material. It's right there. So if you take a left lateral abdominal view and you see a pylorus that's full of gas and there's something sticking into the gas, then you need to be very concerned about the possibility of foreign material stuck at the level of the pylorus. So that's a really significant radiographic feature here. The other significant features are the ones that you mentioned, are the abnormal size, shape, position of the small bowel. So we've got bunching and we've got plication of the small bowel here. And it's the plication that really nails it on as this being a linear foreign body. So linear foreign bodies typically are going to cause the intestine to bunch up around it, it can get plicated, and then because it's all bunched up, you're going to get gas trapped within restricted areas of lumen within the bowel, and then that's going to give you these little comma shapes in the right lateral view, these tiny little focal areas of gas that you wouldn't expect to see. So yeah, good job. So this was absolutely mechanical ileus, fabric foreign body anchored at the level of the pylorus, and then an associated linear foreign body within the small bowel. So yeah, nice job. Anybody have any questions about this case?
Can I ask a question?
Yeah.
The rounded structure just ventral to the pylorus, do you think it's the liver? Yeah, do you think it's the liver? Is one of the liver lobes?
It could be, yeah. I mean, I was just thinking that all of this here is just all stomach. I think this is just really giant stomach. This is kind of here.
Yeah, because you can see, yeah.
I wonder whether that's the caudal margin of the liver just there. And then this margin here is probably stomach. And he's got this giant stomach because of the stuff that's stuck at the level of the pylorus.
Okay, thanks.
Okay, everybody happy with this one? So that's a nice case. And it means that if you guys get another one of these, you're going to take 3 views, a left lateral, a VD, and a right lateral, and you're not going to miss it. So I think 2/3 of you guys actually suggested that you do abdominal ultrasound. I don't think that that's necessarily the wrong thing to do. I think In this case, it was pretty straightforward, identifying the material that was stuck at the level of the pylorus and also the plication, and then that would just give you some additional reassurance before you go and cut this patient. For those of you who are a little bit more brave, I think based on that radiograph and based on the way that that patient presented, it would be entirely reasonable to cut it without necessarily popping the probe on the abdomen. There were enough changes there for you to be super confident that there was something stuck at the level of the pylorus and there was an associated in the foreign body. So I think you were all right, essentially. If you wanted a little bit of additional assurance, then an ultrasound's fine. If you're feeling super confident, then you would have been right to cut it because you would have found that application and that foreign body stuck in the pylorus once you'd opened that. All right. So this is case number 3. This is a 4-year-old male-neutered domestic short-haired cat. It's had an RTA and it's sustained some head trauma. So I've given you a couple of skull radiographs. Are always tricky. So who is feeling?
I can give a go.
Yeah, go for it.
So there are 2 orthogonal views, a dorsoventral and a right lateral of a skeletal mature cat. I assume that they have been taken with the animal under GA because the animal is intubated. We can see that there is a metallic implant with a wire at the level of the mandibular symphysis and right mandible. Then this was the easiest part.
So yeah, the cat didn't come like this. So prior to the radiographs, the surgeon responsible for the case had already identified separation of the mandibular symphysis and had applied this wire. So that was a bit sneaky of me not to mention that. So yeah, you're absolutely right. Yeah, wire.
Then on the DV view, I think that there is a fracture line in the rostral part of the maxilla, and you can see actually more on the left side. There is as well like a wound with some sort of emphysema and soft tissue swelling. Then if we move on the lateral, I'm not convinced, but at the level of the right mandible, where I can see a gap between the mandible and the ramus. So I don't know if it actually is a subluxation or another fracture.
Okay.
And yeah, basically that's it. I would probably recommend a CT or like a addition, maybe to rule out a hard palate fracture, probably to take an intraoral view, so we can have like a better outline of the palate.
Yeah, no, I think that's absolutely reasonable. Okay, so skull radiographs always super tricky. So we covered a few bits and pieces with the discussion, but what I'd like to know from you guys is what are you most concerned about here? So are you most concerned about the rostral maxilla? Are you concerned about the TMJs? Is it the right? Is it the left? Are you worried about the zygomatic arch? So hopefully you can now see this question and you can respond. Less responses this time, which probably means you guys are less sure about these skull radiographs, which is absolutely reasonable. So let's just sync it up. Okay, so such responses, that's good. All right, so right TMJ is the winner, closely followed by left TMJ, and then some of you are also concerned about the rostral maxilla. Yeah, no, I think that's fine. So whenever we're asked to look at skull radiographs when patients have sustained trauma, one of the things that's super important is trying to decide whether or not the TMJs are normal. Because if they're not normal, then it means that it's unlikely that patient will be able to eat might require an esophageal feeding tube and might potentially require some additional surgical intervention to repair whatever fractures, luxations, etc. might be present. So in this case, the surgeon had already identified this separation of the mandibular symphysis, and I popped a wire around the rostral mandible, which is absolutely fine, and there it is. And as B correctly pointed out, there is a fracture here. So this rostral maxilla is fractured, and the left maxilla is displaced rostrally relative to the right. So there's certainly at least one skull fracture here. There are probably more. We can see the zygomatic arches, and we can see the mandibles just here. You can't really see much of the palatine bone because of the superposition of the rostral mandible. And then we need to try and decide where the TMJs are and whether or not they are intact. And knowing which bit to look at is kind of the trick here. So the TMJs are just here, and they're just here. So this is the mandible. This is the mandibular ramus just here, and then this is the condylar process of the mandible on the left, which is articulating with the temporal bone. And on the right, we've got the mandible, we've got the mandibular ramus here, and then we've got the condylar process of the mandible just here. And one of the things that caught my eye when I was looking at these radiographs is the difference in terms of the space between the temporal bone and the condylar process of the mandible on the right versus the left. So here it's nice and small and clearly marginated, and here it just looks like it's much wider. So I was certainly concerned that there could be something going on with this right TMJ. I wasn't so sure that I thought that I could see a fracture here, but certainly potentially a luxation or a subluxation. That was my main concern looking at these radiographs. This is pretty oblique, this view, so it's not a straightforward lateral view, because if it was, then we wouldn't be able to see both of the tympanic bullae. So that's one bulla, and that's another bulla. And if this was a beautiful lateral view, you wouldn't really be able to see both mandibles either, because they should be lined up beautifully and superimposed one on top of the other. So this is an oblique view, and honestly, it's really tricky to know whether this is the right mandible, or this is the right mandible, or this is the left, and this is the right. I think without knowing what sort of oblique view it is, it's really tricky to tell. So I would be super cautious about making too many calls based on an oblique view like this. Again, you need to ask yourself the question, well, is it even possible to see the temporomandibular joints in this view? And I think you can see them. It's tricky to see. So that's the mandible there, whichever one it is, right or left. That's the mandibular ramus there, and then we can see that the condylar process is just there. So that's one of the TMJs, but it's tricky really to be confident about evaluating it because of all the superposition. And then for the other one, the mandible here, we've got the ramus here, we kind of follow it around, and maybe it's there. Maybe that's a TMJ just there. And they don't look too bad actually in this radiograph, but again, there's so much superposition, it's really tricky to know what's going on. In this oblique view, you can see the palatine bone here, and then we're going to get to the pterygoid bones here, and it does look like there's a bit of discontinuity here, so it could be that there's a fracture there, but it's really tricky to tell. So really, we need to investigate this further, and as B suggested, the way to investigate this further is going to be to do a CT. Fortunately, we have a CT to look at. So this is a bone reconstruction. If I remember rightly, this is a 1.25 millimeter bone reconstruction. So I'm just going to play this through, and you guys can just take a little look. That's it. So one of the things that I should say is that prior to the radiographs, the wire on the rostral mandible was applied. Prior to the CT, the wire was removed. So there's no wire in the CT. All right, the rest of it is pretty boring. So the first thing that we're going to have a look at is the area that the wire was in contact with. So here we can actually still see a gap between the right and left mandibular symphysis, but the wire had been on for a wee while. It felt very stable, so hopefully all this is fibrosed and shouldn't necessarily cause us any problems in the future. Let's just run this on slightly. So hopefully you guys can appreciate just here, there's a little bit of periosteitis that is associated with that wire. Just there. Let me show it to you. There we go. So just here, there's some aberrant bone present. Now we know that this cat has had a wire on this rostral mandible, so that's probably nothing to worry about. It's just a bit of reactive bone as a result of having that wire placed on the rostral mandible. So we'll continue. Actually, let's just go cranially again. Let's just confirm the fact that there absolutely was a fracture of that rostral maxilla, and there absolutely was just here. So that's confirming our suspicions based on the radiograph. We'll move caudally. We'll see if we can see any more fractures. So just here, there is a fracture of the right zygomatic arch. So if you compare right with left, it should look like this, with beautiful continuous margins between the maxillary bone and the zygomatic bone. We're not seeing that. There's definitely a step there, so there's a fracture affecting that right zygomatic arch. I'm going to move a little bit more caudally. And here, there's a big fracture of the pterygoid bone, just here, which we couldn't really see on the radiograph. And there are a few other fractures dotted around for those of you with eagle eyes. But the thing that we're most concerned about is this right temporomandibular joint. So I'm just going to fan through these TMJs just for a moment. And the left TMJ has got really nice, smooth margins, and it has a really helpful structure called the retroarticular process, which sits just behind the joint, and it's beautifully smooth and complete on the left. If we compare that to the right, immediately we can appreciate that that right TMJ isn't entirely normal. So the articular margins are really irregular, and also the condylar process is abnormal, so there's some sclerosis of that condylar process. And if we just run it on slightly, we just look at that retroarticular process on the right compared to the left, it's much smaller. And there's also a strange looking sliver of bone just adjacent to it, which shouldn't really be there. There's a few other bits and pieces on this CT as well that maybe some of you have spotted. So there's a whole bunch of material in the right and left tympanic cavities. So on top of having multiple skull fractures, this cat also has bilateral non-specific otitis media. So the main reason why I wanted to show you guys this case is really to point out where to look for the temporomandibular joints in skull radiographs, because if you don't know where to look, then you're not going to pick up fractures or subluxations. To just remind you that the VD view is very useful when assessing the TMJs. The lateral view is not so much, and really you need to be acquiring oblique views in cats, for example, to look at the TMJs. So you want to be doing right ventral, left dorsal, and you want to be doing left ventral, right dorsal oblique views to really assess these TMJs comprehensively using radiographs. In dogs, there's a nose-up view you can use. There's also a parallax view, but in cats, you really have to do the oblique views. to see these TMJs with any confidence to assess them comprehensively. And it can be really tricky. And CT is super, super useful when assessing skulls. So however carefully you think you've looked for skull fractures on radiographs, you'll always find additional fractures and additional lesions when you come to look at the CT. So yeah, good job. That was the thing to take away from that case was essentially where to look for the TMJs on skull radiographs. Anybody any questions about that one? In which case, we'll move on to case number 4, which is really young, so 3-month-old male neutered puppet, has a shifting falling lameness. And Giorgio is not allowed to do this one because he would be familiar with it.
Oh,
but
damn
anybody else, but anybody else is welcome to have a pop.
I was going to read your report out, Ian.
Yeah, no, this is a great case, which is why it's included. So anybody else like to have a crack at this one?
I'm happy to have a go.
Yeah, go for it.
So we do have 4 radiographic projection of a skeletally immature dog. We have right forelimb, mediolateral and caudocranial, and the same projection for the left. So the findings, they are pretty similar, but I think the right is the worst leg compared to the left. So the grow plate physis, they are still open, but like the anconial process of the ulna and the tubercle olecrany, so they have a rounded shape in the mediolateral, which I expect this type of appearance, this type of shape in a possible, not in a 12 weeks old dog, but possible in a 8 weeks old dog. Also the shape of the humerus, it looks a bit weird to me, so it's not completely formed. And moving distally to the ulnar physis, so the distal physis of the ulnar is he has a completely, the styloid process, he has a completely square shaped, which normally has a sort of conic, elongated shape, so it's completely squared. And within the distal part of the ulnar, in the essentially medullary part, there are a sort of 2 conic radiolucency, and I may see a sort of in the lateral aspect, I may see a sort of cortical thinning, like a sort of cortical disruption. Yes, there. I'm not totally sure, to be honest, the ulnar physis there is completely closed, and I mean I don't really know if I don't really know the name of the disease in this case, but I'm not sure if it's related with some sort of chondrodysplasia and or possible a sort of previous trauma or osteomyelitis, and as to, subsequent, there is no formation there or no growth, no perfect growth of the styloid process and of the normal antebrachium, essentially.
Yeah, no, I absolutely agree with all of the changes that you pointed out.
Yeah, and I think the lefty looks pretty the same. I mean, yeah, I think it's probably less, severe compared to the right.
Yeah.
You may be seeing the radiolucency in the left one, in the distal part of the ulna, that he hasn't got this conic shape, but is more linear. So possible is more essentially within the metaphyseal part compared to the right.
Yeah, absolutely. Okay. No, I think those are all great descriptions, and yeah, I absolutely agree. So what we're going to do, because this thing is working, which is very exciting, is we're going to just open it up to the floor again and see what you guys are most concerned about. Which bit of these bones do you think is most abnormal and is the thing that we should be paying most attention to? Yeah, a wee bit longer just to allow everybody to respond. All right, let's see what the results are. All right. Yeah, so we've got most people going for the more radiolucent metaphyses that you described as being the most pertinent lesion. Maybe one or two people concerned about the articular surfaces and the epiphyses. So let's go back and have a look at these radiographs again. And we'll look at the right limb, because I absolutely agree that I think the changes are much easier to see and more severe in this right limb. So you have absolutely correctly pointed out this area here. So it's the distal ulnar metaphysis, which is more radiolucent than it should be. So effectively, there's a radiolucent halo that is just bordering this distal ulnar physis region of the distal ulnar metaphysis. And if we kind of squint and look very carefully with a little bit of the eye of imagination, we can maybe convince ourselves that there might be a little bit of lucency associated with that distal radial metaphysis as well. And in the left, again, the change is much harder to see here than they are on the right, but certainly for the ulnar, there is this area of reduced opacity at the level of the distal ulnar metaphysis, and possibly not so much the radius. But these changes are bilateral. I think you guys are right. I'd be concerned about the metaphyses more than the epiphyses or the diaphyses or any other parts of the bone, including the articular surfaces. And this is a very young dog, so this was a 3-month-old. I can't remember if that's correct, the 3 months, but it's certainly a skeletally immature dog, very young dog. And this dog has got radiolucent halos associated with its metaphyses, and they are most severe in the forelimbs, particularly the distal, radial, and ulnar metaphyses. And this is not typical, but certainly compatible with metaphyseal osteopathy, which is also called hypertrophic osteodystrophy. So we think this is a metaphyseal osteopathy. It's typically something that you see in young, large breed dogs. It's often associated with a high plane of nutrition. So young, large breed dogs that have recently been taken on by an owner, and they've gone from getting low quality food at the breeder to getting very high quality food with their new owners. It's usually self-limiting, so it usually gets better just with time. Sometimes the changes can be more severe, so as well as seeing this radiolucent halo, you can see periosteal changes as well, so you can see irregular periosteal reaction starting at the level of the metaphyses and extending proximally up the diaphysis, and typically it's the distal radius and ulna that are most often affected. In terms of other differentials, you mentioned osteomyelitis, and you're absolutely right. So can we completely rule out a hematogenous osteomyelitis here? I don't think we can. It's maybe less likely, but a hematogenous osteomyelitis would look similar. So you would get changes to the metaphyses and the physes in cases of hematogenous osteomyelitis. But the presumptive diagnosis here was metaphyseal osteopathy. Yeah, good job. That was one of Giorgio's cases. So hopefully this beast is doing okay.
Yeah, I can report the pup is doing very well.
Good. So yeah, anybody have any questions about this one? So
how long after would you repeat a radiography study?
To be honest, if this little doggy continues to do well, I probably wouldn't bother repeating the radiographs. So if this was something else other than our presumptive diagnosis of metaphyseal osteopathy, then you wouldn't really expect the dog to get better. So if this was, for example, an osteomyelitis, then it wouldn't have been self-limiting. So for me, if it was clinically indicated, so if the patient didn't respond well to symptomatic treatment given our presumptive diagnosis, then I'd repeat the radiographs. If this doggy is doing absolutely fine, then I'd only repeat them if we need to. Anybody else have any other questions about this little beast? Okay, good. Well, nice job, guys. Thank you for participating in the online polling. That worked reasonably well. So there are other options for these online polls. So